Look at your hand right now. I mean,
Yeah.
really look at it.
Yeah, it's something we completely take for granted.
Right. Take your thumb and gently tap the tip of your index finger. Now touch it to your middle finger. Think about how effortless that feels.
It's automatic.
Exactly. You probably didn't even have to look to know exactly how much pressure you were applying or what the texture of your own skin feels like. But now, imagine if that feeling just vanished.
Oh, that's a terrifying thought.
You could still kind of move those fingers, maybe, but you'd have absolutely no idea what they were touching. You couldn't feel a coin in your pocket. You couldn't tell if a coffee mug was boiling hot or freezing cold. Your hand would become functionally completely blind.
It is a terrifying concept. We usually think of blindness only in terms of our eyes, but the hand is an organ of vision in its own right.
Wow, yeah.
It's our primary interface with the physical universe. And that entire interface, that incredibly complex biological antenna, it all relies on one single, remarkably vulnerable microscopic cable.
And that brings us to the mission for this deep dive. Today, we're decoding that exact cable, the median nerve.
Which is such a fascinating topic.
It really is. We're drawing our insights today from a highly specialized postgraduate level explanatory audio script by Dr. K. Senthilkumaran from the Surgical Thinking Academy. The title is just simply The Median Nerve.
Straight to the point.
Right. But what unfolds in this material isn't just a dry list of body parts for medical students to memorize. It is genuinely the story of what makes us fundamentally human. The source material calls the median nerve the eye of the hand.
Which is such a profound, poetic way to describe it. We tend to think of the human hand purely as a mechanical tool.
Like a biological clamp.
Exactly. A clamp or a lever system made of bones and tendons designed to lift things. But to truly understand the median nerve, you have to completely reframe how you view your own limb. You need to view it as a high-definition sensory receptor.
So let's unpack that, because we have different nerves doing different things in the arm, right? It's not just one wire running the whole show.
Far from it. The text lays out this beautiful trio of the great upper limb nerves. You have the radial nerve, which is essentially what opens the hand.
Okay, so pulling the fingers back to let go.
Right. Then you have the ulnar nerve, which gives the hand its fine intrinsic control. So think of spreading your fingers apart, or a pianist playing complex chords.
Got it.
But the median nerve gives the hand its power grip, and even more crucially, it provides precision sensation.
Precision sensation. Meaning feeling things where it actually counts the most, right? The exploratory digits.
Yes, exactly. We're talking about the thumb, the index finger, and the middle finger. These are considered your precision fingers.
The ones you use for everything.
Right. When you pick up a grain of rice, when you thread a needle, when you assess the microscopic weave of a fabric, you are using the median nerve. If you lose sensation in those specific fingers, your hand might still have some mechanical movement, but because the brain cannot feel what the hand is manipulating, it is effectively blind.
It becomes clumsy.
Yes. Clumsy, hesitant, and functionally useless for any complex task.
It's just incredible to think that a single bundle of fibers is the central conductor of our most uniquely human daily actions. To really grasp how this intricate machinery works and, well, more importantly, how it breaks, we have to trace the wire all the way back to the source. We have to follow the median nerve from the moment it's born.
And its birthplace is high up in the axilla, the armpit.
Which, honestly, doesn't sound very glamorous for such an elegant and important nerve.
No, it really doesn't. But anatomically, the armpit is a massive, complex junction box. It's where the nervous system sorts its wires before sending them down the limb.
Okay.
The median nerve is formed here from two distinct roots. One root comes from a bundle called the lateral cord, and the other from the medial cord. These cords are massive bundles of nerve fibers that have traveled all the way down from the neck.
Was the spinal cord, right?
Yes. Specifically carrying fibers from the spinal cord level C5 down to T1.
So just to be clear, C5 to T1 means it's gathering a massive payload of neurological information from 5 different levels of the spine.
From the lower neck and the very top of the back.
Yeah, and it funnels it all into this one central cable.
That's the core of it. It's a massive convergence. And the way these two roots come together is quite striking, visually. They converge directly around the axillary artery,
which is the main blood vessel for the arm.
the main pulsing blood vessel supplying oxygen to the arm, right? The text describes the nerve roots embracing this artery like the letter M.
I love that visual.
Yeah.
A giant biological letter M wrapping around a pulsing red artery deep in the armpit. It's a great mnemonic for medical students, too. M for median nerve.
It's perfect. Once it forms that M and becomes the fully unified median nerve, it begins its journey down the upper arm. It runs right alongside the brachial artery.
Okay, heading south.
Heading south. But here's the fascinating, almost counterintuitive thing to remember about its journey through the upper arm. It does absolutely nothing.
Wait, nothing. It doesn't plug into the biceps or the triceps.
It gives off essentially no motor branches in the arm itself. It just travels.
See, this is where the engineering of the body is so cool. I was reading this and thinking, the median nerve in the upper arm is exactly like an express train.
Oh, that's a good way to put it.
Right. It completely skips all the local stations, the massive upper arm muscles. It doesn't open its doors to let any electrical signals off. It's saving its entire payload, its full bandwidth, for the major metropolitan hub at the very end of the line.
The forearm and the hands.
And exactly.
That is a brilliant way to conceptualize it. It is an express train carrying highly specialized, critical cargo, and it cannot afford to dilute its power or risk getting damaged by intertwining with the heavy lifting muscles of the upper arm.
Makes sense.
But to get to that metropolitan hub of the forearm, the express train has to cross a very precarious anatomical bridge.
The elbow.
It has to cross the elbow.
And this is where we hit our first major bottleneck. The body is full of these architectural choke points, isn't it?
It is. As the median nerve reaches the elbow joint, it's still lying just medial meaning closer to the inside of the body to the artery.
Okay.
First, it has to slip under a tight, fibrous band of tissue called the bicipital aponeurosis.
Bicipital aponeurosis. I mean, it sounds like a spell from Harry Potter, but what actually is it?
Well, it's essentially a flat, incredibly tough sheet of tendon spreading out from the biceps muscle. It acts almost like a seatbelt, strapping down the structures beneath it.
Okay.
A seatbelt. Right. But once the nerve passes under that seatbelt, it enters the forearm by passing through a literal physical doorway made of solid muscle.
A doorway?
Yes. It goes right between the two heads of a muscle called the pronator teres.
I'm trying to picture a doorway made of muscle. Are you saying the muscle is anchored in two different spots, creating a gap, and the nerve just threads the needle right through that gap?
You've got it. The pronator teres muscle has two origins where it attaches to the bone, and those two origins create a tight V shape, or a slit. The median nerve dives right through that slit to get deeper into the arm. We have to emphasize this specific architectural doorway because anytime a delicate nerve passes through a tight muscular or fibrous tunnel, you have a potential for entrapment.
So if you're a tennis player or a carpenter, constantly twisting your forearm and building up that muscle?
Yes, exactly. If that pronator teres muscle gets hypertrophied, meaning abnormally enlarged from heavy overuse, or if there's localized swelling from an injury, that little muscular doorway becomes a crushing vice.
That sounds incredibly painful.
It is. It's the first major site where our median nerve express train can get delayed or derailed. We'll get into the specifics of that kind of injury a little later, but it's crucial to map the terrain first.
Okay, so the nerve survives the elbow. It threads the needle of the pronator teres. Now it's deep in the forearm. It runs straight down the middle, sandwiched safely between the superficial and deep finger flexor muscles.
And this is where it finally starts working.
Right, it's finally making local stops, dropping off motor branches to power the arm. But before it gets to the wrist, there is a tiny anatomical detail in the text that feels like a massive aha moment. It's a literal diagnostic cheat code for doctors.
Ah, you're talking about the palmar cutaneous branch.
Yes.
Yeah.
Okay, so as the main nerve gets close to the wrist, it's about to enter the infamous carpal tunnel.
Right.
But about 5 centimeters before it hits that tunnel, it branches off a tiny, seemingly insignificant wire. This is the palmar cutaneous branch, and its only job is to supply feeling to the skin of the thenar eminence.
For our listeners, the thenar eminence is that fleshy muscular mound at the base of your thumb, right on your palm.
Right, but here's the crazy part. This tiny branch, this little wire, does not go through the carpal tunnel with the rest of the nerve.
Nope.
It passes in front of the flexor retinaculum, which is the thick, fibrous roof of the carpal tunnel. It completely bypasses the tunnel.
It's a detour.
Exactly. So my immediate thought when I read this was, why does it matter if one tiny microscopic wire goes over a ligament instead of under it?
Well, it matters immensely from a clinical perspective. It is, as the source points out for its postgraduate audience, a beautiful localizing sign.
A localizing sign.
Think about it like a diagnostic shortcut. If a patient comes into a clinic complaining of severe numbness in their fingers, the doctor has to figure out exactly where the median nerve is being pinched.
Okay.
Is it being suffocated at the wrist in the carpal tunnel? Or is it being crushed way up at the elbow in that pronator teres doorway we just talked about?
Because the treatment for those two things would be wildly different. I mean, you don't want to cut open a wrist if the problem is at the elbow.
Precisely. And because of this one little branch going over the tunnel, the doctor has an instant definitive clue. Because the palmar cutaneous branch bypasses the carpal tunnel, it is completely spared in carpal tunnel syndrome.
Okay.
Right. If the tunnel is crushed, the main nerve is crushed, so the fingers go numb. But that little branch running safely over the roof, it's perfectly fine. So the skin over the ball of the thumb keeps its normal, healthy sensation.
That is just brilliant. The doctor touches the ball of the thumb with a pin, and if the patient says, yep, I feel that perfectly, but their index finger is totally numb, the doctor instantly knows the problem has to be at the wrist.
Exactly. The X marks the spot at the carpal tunnel.
But what if it's the elbow?
Well, if the doctor touches the ball of the thumb and the patient says, no, that's completely numb too, the doctor knows immediately that the injury cannot be carpal tunnel syndrome.
Because that little branch is dead, too.
Right. The nerve must be trapped higher up the arm, way back up near the elbow, before that tiny palmar cutaneous branch even had a chance to split off.
That's incredible.
Sensation over the thenar eminence is the ultimate clue to the level of the injury. It is anatomical detective work at its finest.
The body has built-in diagnostic cheat codes if you just know how to read the wiring diagram. I love that.
It's elegant.
So we know the path of the express train now, and we know its clever little bypass trick. Let's unpack its actual payload. What does this massive nerve actually power once it arrives in the forearm and hand?
The source breaks the motor supply down into three very distinct parcels. First, as we mentioned, it finally starts dropping off passengers in the forearm. It supplies most of the flexors and the pronators.
Flexors being the muscles that bend the wrist and fingers, pronators being the muscles that turn the palm face down.
Exactly. It powers the pronator teres, the radial wrist flexor, the palmaris longus, and the superficial finger flexors. That's parcel 1.
Okay, parcel 2.
Parcel 2 happens deep in the forearm. The median nerve gives off a very special, secluded branch called the anterior interosseous nerve.
That's a mouthful.
It is. This branch dives deep against the membrane between the forearm bones and is purely motor. It carries absolutely no sensory fibers.
Not at all.
None. It supplies 3 deep muscles, the long flexor of the thumb, the deep flexor to the index and middle fingers, and the pronator quadratus near the wrist.
I want to pause on that deep branch for a second. Why would a branch be purely motor? I mean, wouldn't it need sensory fibers to tell the brain what the muscles are doing?
That's a really great observation. Muscles do have tiny sensory receptors called muscle spindles that report stretch back to the brain, and those proprioceptive fibers are carried in this nerve.
Okay.
So when we say purely motor in a clinical sense, we mean it has no cutaneous sensory fibers. It doesn't supply any skin.
Oh, I see.
Its only job is mechanical execution. It controls the terminal microscopic joints of those specific digits, the very tips of your thumb and your 2 precision fingers. It's the ultimate fine-tuning mechanism.
The precision wiring. And then we reach parcel 3, the final destination, the hand itself.
The metropolitan hub. Here it supplies the thenar muscles, the muscles making up the ball of the thumb. The text uses a classic medical mnemonic here, LOF, LOAF.
Okay, let's spell out the LOF for everyone.
Well, L is for the lateral 2 lumbricals.
Wait, let me stop you there. What on earth is a lumbrical? That sounds like an earthworm.
It does, doesn't it? The word actually comes from the Latin word for earthworm, because they are tiny worm-like muscles.
You're kidding.
I'm not. But their function is fascinating. Unlike most muscles that connect bone to bone, lumbricals are bizarre because they originate from a tendon and insert into another tendon.
From a tendon to a tendon.
Yes. They originate deep in the palm from the flexor tendons, and they reach around to pull on the extensor expansion on the back of the fingers.
Pulling a tendon with another tendon, what does that actually achieve?
Try this. Keep your fingers perfectly straight, but bend your hand at the knuckles so your fingers are at a 90-degree angle to your palm.
Okay, like I'm making a tabletop with my fingers.
The lumbricals do that. They flex the base of the fingers while simultaneously keeping the tips rigid and straight. It's a highly complex biomechanical pulley system.
Wow. Okay, so L is lateral 2 lumbricals. What about O, A, and F?
O is for opponens pollicis. A is for abductor pollicis brevis, which pulls the thumb out and away from the palm. And F is for flexor pollicis brevis, which bends the thumb inward.
Lateral two lumbricals, opponens pollicis, abductor pollicis brevis, flexor pollicis brevis, the LOAF.
That's the LOAF.
Out of that entire group, I really want to spend some time on the O. The opponens pollicis. This word opposition, it gets thrown around a lot in biology, anthropology, documentaries when we talk about primates and human evolution. What does it actually mean to oppose the thumb from a strictly mechanical standpoint?
Well, if we connect this to the bigger picture of human evolution, opposition is everything. It is the single movement that unlocked advanced tool use, fire building, and eventually human civilization.
Huge claims for one little muscle.
But true. Mechanically, opposition isn't just closing your thumb like a hinge. It's a complex, rotary swinging motion. The opponent's pollicis muscle pulls the thumb out, rotates the bone on its axis, and swings it across the palm so that the fleshy pad of the thumb directly meets the fleshy pads of the other fingers.
It's what allows you to pinch a pencil or grip a hammer handle securely or type on a smartphone.
Exactly. Most mammals do not have this. Think of a dog's paw, or even some lower primates. Their digits fold in parallel, like the teeth of a rake.
Right.
To swing a digit perpendicular to all the others and meet them perfectly pad to pad requires incredibly specialized joints, specifically the saddle joint at the base of the thumb. But a joint is useless without a motor.
It needs the power.
And it requires a highly specialized nerve to coordinate that microscopic rotational precision. The median nerve is what lets the thumb swing across. As the text implies, it's the movement that separates the human hand from the rest of the animal kingdom.
It's breathtaking when you take a step back and realize how much of human history. I'm painting the Sistine Chapel, forging bronze swords, performing open-heart surgery, playing the violin. It all relies entirely on that one specific muscle being powered by this one specific nerve.
It really does.
But as we established at the start, it's not just about movement. We have to talk about the sensory map. We talked about it being the eye of the hand.
Yes, the sensory map of the median nerve is incredibly specific. It supplies the palmar surface, the palm side of the thumb, the index finger, the middle finger, and exactly half of the ring finger.
Just half of the ring finger. That seems like a design flaw. Why split a finger down the middle?
It seems strange, but it's split perfectly down the longitudinal axis. Just the lateral half, the side facing the middle finger, is median territory. The other half belongs to the ulnar nerve.
Okay.
So the median nerve handles 3.5 fingers total. And here is a crucial detail. It also supplies the skin over the very tips and the nail beds on the back of those exact same fingers.
I was wondering about that when I read the notes. Why only 3.5 fingers? And why do the nail beds get included on the back when the entire rest of the back of the hand is covered by a completely different nerve, the radial nerve? It seems so arbitrary.
It seems arbitrary until you think about how you physically interact with the world. Think about the sensory intensity of the pinch mechanism we just discussed. When you reach out to touch something potentially dangerous, something hot, sharp, or unknown, you don't lead with your pinky finger.
No, definitely not.
You lead with your thumb and index finger. These are exploratory biological feelers.
Right. If I'm trying to figure out if a pan is hot, I tap it with my index finger.
Precisely. They are constantly interacting with the environment. Therefore, they require immense neurological bandwidth compared to the rest of the hand.
Okay, that makes sense.
If you look at a sensory homunculus, the map of how the brain visualizes the body, the thumb and index finger are drawn as massive swollen structures because a massive percentage of your brain's sensory cortex is dedicated exclusively to them.
Just for those fingers.
The brain needs high-definition sensory data from the surfaces that actually grip the object. And when you pinch something hard, you aren't just using the palm side of your fingertip. Pressure is applied all the way around the tip of the finger, pushing the skin up against the nail.
Oh, I see. So the nerve wraps around the back to include the nail beds to complete the sensor package.
Yes. Including the nail beds ensures the brain gets a complete 360-degree sensory picture of exactly how hard you are pinching, preventing you from crushing a delicate object or dropping a heavy one.
The wiring is perfectly evolutionarily optimized for the pinch. The brain dedicates the express train's most precious cargo to the exact spots where we interface with the physical world. A simple, brilliant summary from the text. The median nerve pronates the forearm, flexes the wrist and fingers, opposes the thumb, and feels the precision fingers.
Which is a flawless physiological summary. But having established this pristine evolutionary marvel of function, we must now look at what happens when the architecture closes in on it.
Ah, right.
Which brings us to the dark side of this anatomy, the breakdowns.
We know how it's supposed to work. Now we look at how it fails. Let's start at the most common pinch point in the entire human body, the wrist. The source material refers to this as a low lesion.
The wrist is the classic site of a low lesion, and the absolute titan of low lesions, the one everybody has heard of, is carpal tunnel syndrome, or CTS.
It's practically a household name. I mean, everyone knows someone who wears those rigid wrist braces to bed.
It is ubiquitous because it is the most common entrapment neuropathy in the body. But to understand why it happens, you have to visualize the anatomy.
Let's do it.
The carpal tunnel is exactly what it sounds like. It's a tight, rigid, non-expanding tunnel at the base of the hand. The floor and the walls are made of the actual carpal bones, the wrist bones arranged in a U shape. And the roof is that thick, unforgiving band of tissue we mentioned earlier, the flexor retinaculum.
And the median nerve has to go through this tunnel. But it's not alone in there, is it? It shares the space with a bunch of tendons.
Yes, and this is the crux of the problem. 9 long flexor tendons. The cables that bend your fingers share that exact same tight space with the median nerve.
9 tendons plus the nerve.
So you have 10 structures packed into a rigid bone and ligament tube. There is virtually 0 extra room. It is packed to capacity by default.
Wow.
So if anything causes the contents of that tunnel to swell even a fraction of a millimeter, or if the tunnel itself gets physically smaller, something has to give. The tendons are tough, fibrous cables. The bones are bone. The median nerve is the softest, most delicate thing in there, so it gets compressed.
Now, I always thought carpal tunnel was purely an occupational hazard. You type too much, you play too much piano, you get repetitive strain, just mechanical wear and tear. But the text lists some genuinely surprising systemic triggers. It says it can be idiopathic, meaning we don't know the exact cause, but it can also be driven by pregnancy, hypothyroidism, rheumatoid arthritis, diabetes, and acromegaly.
The occupational link is well known, but the systemic causes are fascinating and often overlooked by the general public.
It's wild to me that a hormonal issue, like a thyroid problem or being pregnant, can literally manifest as a numb thumb. I'm stuck on this. How does a thyroid problem crush a nerve in your wrist?
It comes down to fluid dynamics and cellular metabolism. Let's take hypothyroidism. When your thyroid is underactive, your overall cellular metabolism slows down.
Okay.
This leads to the accumulation of certain complex sugar molecules called mucopolysaccharides in the connective tissues throughout your body.
Mucopolysaccharides.
Yes. These molecules are highly hydrophilic. They draw in and trap water. So the soft tissues lining the tendons in the carpal tunnel literally swell up with trapped fluid.
From the water.
Right. Pregnancy operates on a similar physical principle, though a different mechanism, hormonal shifts, cause massive systemic fluid retention. Rheumatoid arthritis, on the other hand, is an autoimmune condition where the body attacks the synovial lining of the tendons, causing them to become chronically inflamed and physically thickened. Diabetes causes metabolic changes that make the nerves themselves more susceptible to compression damage. And acromegaly, which is an excess of growth hormone, literally causes the bones and connective tissues to physically grow and thicken, shrinking the tunnel from the outside in.
Okay, I have an analogy for this. Tell me if this works to visualize the fluid swelling. The carpal tunnel is like a crowded subway car at rush hour.
Okay, I like that.
The median nerve is just one passenger trying to get to work, standing shoulder to shoulder with 9 other passengers, which are the flexor tendons.
I'm following you.
If the systemic condition, like the pregnancy fluid retention or the mucopolysaccharides from a thyroid issue, makes everyone in that subway car suddenly put on a giant, puffy winter coat.
Oh, that's good.
The physical size of the subway car, the tunnel, hasn't changed at all. But suddenly the volume inside has swelled immensely. And because the nerve is the softest passenger, it's the one getting brutally crushed against the rigid doors.
That is an exceptionally accurate, vivid analogy. The systemic conditions are the puffy coats. They invisibly crowd an already unforgiving space. The pressure inside the tunnel rises. The microblood vessels supplying the nerve get squeezed shut. The nerve starts to suffocate, and it misfires.
And that's the pain.
That misfiring is the tingling and numbness you feel.
And it's not just slow-building systemic issues or typing. The text mentions traumatic, instant injuries at the wrist, too.
Yes. Beyond the slow, agonizing crush of CTS, you have sudden, violent traumatic divisions, a laceration from falling through a glass window or slipping slipping while using a kitchen knife.
That sounds awful.
Or a collis fracture, which is an incredibly common break of the radius bone in the wrist, usually happening when you try to catch yourself during a fall. Or even a dislocated lunate.
Lunate.
The lunate is a tiny wrist bone shaped like a crescent moon. In high-impact trauma, like a car crash, that little bone can pop completely out of place and slam directly forward into the carpal tunnel, crushing the nerve instantly.
So if a patient has a low lesion at the wrist, whether from a puffy coat subway crush or a pane of glass or a displaced moon-shaped bone, what is the functional fallout? What does their arm actually look and feel like?
A pure low lesion paints a very specific clinical picture. Because the injury is at the wrist, everything the nerve did before the wrist is perfectly fine.
Right, because the express train already let off its passengers. The branches for the forearm flexors and pronators got off stations ago.
Exactly. So the forearm muscles are entirely intact. The patient can still forcefully bend their wrist and bend most of their fingers using the muscles located in the forearm.
Okay, so the arm is fine.
The functional disaster is strictly localized to the hand. They will have wasted, shriveled the thunar muscles, that olive group we talked about, so they lose the evolutionary power of thumb opposition.
The thumb just goes flat.
The thumb just lies flat. And they will have profound numbness, or that agonizing burning pain, in those 3.5 precision fingers. Wasted thumb, numb precision fingers, but a completely normal, strong forearm. That is your classic low lesion.
Which is debilitating enough. I mean, if you can't pinch, you can't button a shirt or turn a key. But what happens when the damage is higher up? Because if a wrist injury is a local power outage affecting just one neighborhood, an injury higher up the arm takes down the entire power grid.
It does.
We are moving back up the arm to the elbow and the upper forearm, the realm of high lesions.
High lesions are a much more catastrophic event for the limb's overall function. The classic traumatic cause described in the source is a supracondylar fracture of the humerus.
Supracondylar humerus fracture. That's a mouthful. Let's translate that for the listeners.
The humerus is your long upper arm bone. Just above the elbow joint, the bone flares out into 2 bony bumps called epicondyles.
Okay.
Supra simply means above. So a supracondylar fracture is a break just above the elbow joint. It is notoriously common in children.
Why children specifically?
Because of the way they fall. Imagine a kid falling off monkey bars or a trampoline. Their instinct is to throw their arm out perfectly straight to break the fall. The force travels up the forearm and snaps the humerus right at its weakest point above the elbow.
And it's a violent injury.
Extremely violent. And because, as we established way back in the armpit, the median nerve and the brachial artery are traveling side by side right down the front of the arm, they cross directly over the front of that elbow joint.
Oh, no.
When the bone snaps, the jagged, razor-sharp edges of the humerus get pushed forward, threatening to slice, stretch, or crush both the nerve and the artery simultaneously. It is an absolute orthopedic emergency. If the nerve is severed here, you lose the forearm flexors, the pronators, and all the hand muscles.
Total sensory and motor blackout. But the text also gets into some really fascinating postgraduate nuances here. Some rare, sneaky syndromes that cause high lesions without a broken bone. Let's talk about pronator syndrome.
Ah, yes. Remember that physical doorway we talked about earlier? The slit between the 2 heads of the pronator, teres muscle near the elbow?
The first bottleneck for the express train.
Right. Pronator syndrome is the entrapment of the nerve right there at that muscular doorway, or sometimes just under the bicipital aponeurosis seatbelt.
Okay.
Now, the expert postgraduate challenge here is knowing how to differentiate this from carpal tunnel syndrome. Because both conditions cause median nerve symptoms, right? Numbness, tingling, weakness in the hand.
So the patient comes in with a numb thumb, and the doctor has to play detective. They have to know if the subway is crowded at the wrist or if the door is jammed at the elbow. How do they figure it out?
The clinical presentation of pronator syndrome has 3 very distinct clues that set it apart from CTS. First, it causes severe aching pain in the fleshy part of the upper forearm, not just localized wrist pain.
Oh, yeah.
Second, it notoriously spares night symptoms. Carpal tunnel is famous for waking people up at 3 a.m. in agonizing pain. Pronator syndrome usually doesn't.
I'm curious about the mechanism there. Why does carpal tunnel wake you up, but elbow entrapment doesn't?
Because carpal tunnel pressure often increases when we sleep due to 2 factors. First, systemic fluid redistributes when we lie flat, pooling slightly.
Makes sense.
Second, people naturally tend to curl into a fetal position when they sleep, bending their wrists inward. Flexing the wrist physically crushes the carpal tunnel.
And pronator syndrome.
Pronator entrapment is different. It's a dynamic, mechanical pinch tied to actively using and contracting the forearm muscles during the day. When you sleep, the muscle relaxes, so the pinch eases. And the third, most crucial clue goes back to our favorite diagnostic cheat code.
The palmar cutaneous branch. I knew this was coming back.
Yes. In pronator syndrome, the nerve is trapped way up near the elbow. This is long before the palmar cutaneous branch even exists. So the entire nerve, including the fibers destined for that little bypass wire, is suffocated.
So it's all numb.
Therefore, a patient with pronator syndrome does have a completely numb central palm and a numb ball of the thumb.
Boom. The detective work is so incredibly satisfying when you know the map. Okay, there is another rare one here. Anterior interosseous nerve syndrome, or Kilo-Nevin syndrome.
This is a fascinating anomaly. Remember that deep parcel of motor supply we talked about? The branch that dives deep against the bone to supply the very tips of the thumb and index finger?
Yeah, the purely motor one that doesn't feel anything.
If only that specific deep branch gets injured, say, from a very localized fracture of the radius bone or an inflammatory autoimmune condition like Parsonage-Turner syndrome that selectively attacks certain nerve branches, you get a very bizarre, highly specific presentation.
What does it look like?
You get a pure motor palsy, a very specific mechanical failure of the pinch mechanism, but with absolutely zero sensory loss.
So the patient's hand feels totally normal. They can feel heat, texture, pinpricks.
Yeah.
But if you ask them to pick up a dime, the mechanics are just broken. The terminal joints won't bend.
Exactly. The sensory wires are on the main highway, which is fine, but the deep motor wire is cut. But before we move on from the high lesions, we absolutely have to talk about the anatomical curveball, the Martin Gruber anastomosis.
Oh, yes. When I read this part of the text, my mind was genuinely blown. We spent all this time memorizing these perfect, precise pathways, and then the body throws this at us. This feels like a literal glitch in the human matrix. Let's break it down.
It definitely challenges our desire for that clean, binary, textbook precision we always hope for in medicine.
So an anastomosis is basically a connection, a bridge, right? The text says this is a relatively common crossover of nerve fibers, from the median nerve to the ulnar nerve, occurring right in the middle of the forearm.
Right.
So visualize this. You have these two separate biological highways, the median nerve and the ulnar nerve, running parallel down the arm, heading to completely different destinations in the hand. And midway down the arm, a bunch of median fibers just decide to jump the median strip, cross the gap, and merge onto the ulnar highway.
That is exactly what happens in about 15 to 20% of people.
But why? Why would the body evolve a glitch like that? Is it a backup generator? A failsafe?
It's a great question. It's likely an evolutionary relic or a developmental quirk rather than a designed failsafe. During embryonic development in the womb, the median and ulnar nerves form from the same initial tissue masses in the limb bud.
So they get tangled.
Sometimes, as the arm lengthens and the tissues differentiate, the wires get crossed during construction. It's not necessarily a purposefully designed backup generator, but it can occasionally function like one by sheer accident.
But isn't that incredibly confusing for a doctor trying to diagnose a severe trauma? Think about it. If a surgeon sees a patient whose median nerve was completely severed at the elbow, they expect all the median muscles in the hand to be dead. But if some of those median fibers jumped over to the ulnar nerve below the cut, wait, no, if the cut is above the
You're seeing the chaos it creates. Let's trace it carefully. Let's say a patient has a severe median nerve injury high up at the elbow. The doctor naturally expects complete paralysis of the thenar OLOF muscles in the hand.
because the nerve is cut.
But because of a Martin Gruber anastomosis, some of the motor fibers intended for those thumb muscles might have been traveling down the ulnar nerve the whole time, bypassing the injury site at the elbow entirely before jumping back to their proper destination in the hand.
Wow.
So, despite a totally crushed median nerve at the elbow, the thumb might still have confusing, unexplainable movement.
So the doctor looks at the thumb moving and thinks, oh, thank God, the median nerve must be fine. But they are being tricked. The signals are just taking a detour on the ulnar highway to bypass the traffic jam.
Exactly. It creates highly atypical confounding patterns of weakness. It forces doctors to abandon the textbook, become true anatomical detectives, and use advanced electrical testing machines to map exactly where the electrical signals are traveling.
It's just wild.
It proves that human anatomy isn't a rigid blueprint. It's a living, highly variable, chaotic landscape.
All right, moving to the next major phase of our exploration. We've talked extensively about the internal damage the crushing and cutting of the microscope acquires, but the symptoms are dramatically physically visible. How do these silent, paralyzed muscles physically deform the living hand?
This is where we get into the classic clinical pictures. The text outlines 3 famous, instantly recognizable hand postures associated with median nerve damage. The first is the hand of benediction, also historically known as the oath hand or the pointing index.
Hand of benediction, like a priest giving a blessing, holding up 2 fingers.
Exactly. This posture occurs in a high lesion, meaning the damage is at the elbow or above. Now, to see this deformity, you have to ask the patient to do something very specific. You ask them to make a tight fist.
Okay, I'm trying to visualize the biomechanics of this. Why ask them to make a fist?
Because making a tight fist requires all the flexor muscles in the forearm to fire simultaneously. But remember the anatomy. The median nerve controls the flexors for the thumb, the index finger, and the middle finger.
Okay.
So if the median nerve is completely knocked out at the elbow, those 3 specific fingers receive absolutely no electrical signal to bend. The muscles are dead. They remain completely paralyzed and stick out perfectly straight.
But the ring and pinky fingers still bend. Why?
Because the deep flexors for the ring and pinky fingers are wired to a completely different circuit, the ulnar nerve.
Oh, of course.
So when the brain says make a fist, the ulnar nerve successfully fires and the ring and pinky fingers curl normally and tightly into the palm. You are left with the thumb, index, and middle fingers pointing rigidly upward in paralysis, while the other 2 are curled tight in action. It looks exactly like a frozen, dramatic gesture of blessing.
That is such a striking, undeniable image. But you mentioned a contrast in the notes that medical students must never ever confuse.
Yes. It is the golden rule for students on the neurology ward. It is very easy to superficially confuse the median hand of benediction with another famous deformity called the ulnar claw.
They look similar.
They look vaguely similar to an untrained eye. Some fingers are straight, some fingers are curled, but they are absolute fundamental opposites in their biomechanical mechanism.
Let's force a strict contrast here to prevent any listener confusion.
Yeah.
So if I walk into a clinic and see someone just resting their hand comfortably on a table, completely relaxed, not trying to do anything, and it looks clawed with 2 fingers curled up, that's not the median nerve.
That is emphatically not the median nerve. That is the ulnar claw. The ulnar claw is present at rest when the patient isn't trying to move at all, and it primarily involves the ring and little fingers being physically stuck in a curled, clawed position due to a complex imbalance of muscle tone. The median benediction hand, on the other hand, only appears when the patient is actively trying to make a fist, and it involves the failure of the index and middle fingers to curl. As the text summarizes brilliantly, same looking words, opposite fingers, opposite mechanism. Benediction is median, attempting a fist. Claw is ulnar, at rest.
That clears it up perfectly. It's all about active movement versus passive rest. Okay, what about the second classic deformity, the ape thumb or simian hand?
This one is tragic because it represents the loss of our evolutionary leap. It occurs in both high and low lesions. Whether the nerve is crushed high at the elbow or slowly squeezed low at the wrist in the carpal tunnel, the final destination, the thenar muscles, is starved of its signal.
The oloef muscles waste away and physically shrink.
Precisely. With the abductor and opponens muscles of the thumb wasted away, the thumb loses its superpower. It can no longer swing forward out of the plane of the palm. The mechanics just fail entirely.
So it just hangs there.
Without the muscle tone holding it in position, the thumb falls backward, lying entirely flat alongside the index finger, completely parallel and in the exact same plane as the rest of the palm.
And because it visually mimics the parallel, non-opposable hands of a non-human primate, they call it the ape hand. True opposition and the complex pinch are totally lost.
And the third posture is the flat OK sign. This relates directly back to that anterior interosseous syndrome we discussed, the pure motor palsy of the deep branch.
Right, the secluded branch that just controls the very tips of the thumb and index finger. I want listeners to try this one.
Yes, try making an OK sign with your fingers right now. Bring the very tip of your thumb to the very tip of index finger to form a perfect round circle. A healthy hand flexes those terminal microscopic joints to make a round O.
Okay, got my round O.
But a patient with a damaged anterior interosseous nerve physically cannot bend those terminal joints. The joints remain locked perfectly straight, so instead of a round circle, the flat pads of the fingers mash awkwardly together into a flat, collapsed triangle.
A flat triangle instead of a round circle. And the giveaway, again, is that they have no sensory loss whatsoever.
Correct. But while we're talking about sensory loss, we must not forget the absolute nightmare that occurs with full, severe median nerve injuries. It isn't just about strange hand postures or dropping coins.
Right. The test mentions marktrophic changes and something deeply unsettling called causalgia.
Yes. When the precision fingers go completely numb, it is the most disabling sensory loss possible in the upper limb. You drop things constantly, you unknowingly burn yourself on stoves, you lose all fine motor confidence.
It's functionally blind.
Furthermore, you develop trophic changes. Trophic refers to cellular nutrition. When a nerve dies, the skin it supplies literally deteriorates. It becomes paper thin, shiny, completely loses its ability to sweat, and the nails become brittle and deformed. All because the background nerve supply regulating the microscopic health of those tissues is gone.
The nerve literally keeps the skin alive.
Yes. And then there's causalgia. Causalgia is a severe, relentless, agonizing burning pain. The median nerve is classically, historically notorious for producing the specific type of pain when it is partially injured or crushed. It is not an ache. It is a disabling, fiery, electrical pain that can consume a patient's entire psychological focus.
It's terrifying. Which naturally brings us to the next phase, the detective work. We know what the catastrophic damage looks like and feels like. So how does a modern medical professional rigorously prove which invisible microscopic wire is failing and exactly how badly it's failing?
It starts with understanding the severity of the damage at a microscopic cellular level. The text heavily references two foundational classification systems used by surgeons worldwide, Seddon's 3 types of injury and Sunderland's 5 degrees.
Okay, let's break those down because this gets into the real biophysics of nerve trauma. Let's start with Seddon.
Seddon divides nerve injuries into 3 straightforward, ascending categories. The mildest is neuropraxia. This is essentially a temporary conduction block. The nerve itself is physically, structurally, completely intact, but it's been bruised or squeezed just enough that the electrical signal halts.
Like a kink in a wire.
Mild carpal tunnel syndrome, or falling asleep on your arm weirdly, is often a neuropraxia. It is fully recoverable once the external pressures are moved.
The analogy I've heard is stepping on a garden hose. The hose isn't torn, it's not broken, the water just stops flowing. The second you step off the hose, the water flows perfectly again.
That is a flawless analogy. The second type in Seddon's system is axonotmesis. This is significantly more severe. To understand this, you need a mental model of a nerve. A nerve isn't just one solid wire. Think of a massive transatlantic fiber optic cable.
Okay.
Inside the massive outer cable, there are thousands of tiny individual glass wires, and each glass wire lives inside its own protective plastic guiding tube.
Okay, I have that image. The big cable, filled with little tubes, filled with tiny wires.
In axonotmesis, the actual internal wire, the axon, snaps from the trauma, but the protective guiding tube around it remains completely intact.
So the wire is broken inside the tube. Can it be fixed? Does it heal?
Yes, but incredibly slowly. The broken axon has to physically regrow from the exact point of injury, all the way down the arm, millimeter by excruciating millimeter.
A millimeter a day, right?
Exactly. But because the protective guiding tube is still intact, the new axon knows exactly where to go. It just crawls blindly down that preserved tunnel until it miraculously reaches the muscle again.
And what happens if the tube is broken? Which brings us to the third type.
That is neuromesis. The worst case scenario. This is complete division. The glass wire is cut and the plastic guiding tube is cut. The entire fiber optic cable is sliced in half. An X-Acto knife or a shard of glass went all the way through. This will never, ever recover on its own. The regrowing axons have no guiding tubes to follow, so they just grow into a painful, tangled ball of scar tissue. It requires urgent surgical repair to painstakingly sew the microscopic tubes back together so the axons have a path to follow.
And how does Sunderland's 5 degrees fit into this? Does he disagree with Seddon?
He doesn't disagree. Sunderland just refines Seddon's system by getting extremely granular about exactly which microscopic layers of the nerve's coverings are torn.
So it's just more specific.
Right. The nerve has 3 layers. The endoneurium wrapping the individual axon, the perineurium wrapping bundles of axons, and the epineurium wrapping the whole nerve. Sunderland breaks down exactly which of those microscopic sheaths has snapped.
Okay, I'm following.
Sunderland 1 is neuropraxia. Sunderland 2 is an axon snapping inside an intact endoneurium. Sunderland 3 means the endoneurium tor. Sunderland 4 means the perineurium tor. And Sunderland 5 is the complete slice neuromesis. But practically, in the emergency room, both systems exist to help the doctor make one crucial, high-stakes binary decision. Do we wait for it to heal naturally, or do we take them to the operating room immediately?
So to make that high-stakes decision, they have to do the bedside physical tests. What does a doctor actually do in the exam room to test the median nerve? You can't just stare at the arm.
They systematically test the anatomy we just spent time learning. The purest, most isolated test of median motor function is testing palmar abduction. You ask the patient to lay their hand flat on a table, palm facing up, and point their thumb straight up toward the ceiling.
Yeah.
The doctor then physically pushes down hard on the thumb while the patient forcefully resists. This perfectly isolates the abductor pollicis brevis muscle. While doing this, the doctor looks and feels for any wasting or softness in the thenar eminence.
And they test the opposition, the evolutionary swing, by having the patient forcefully touch their thumb to their little finger.
Right, exactly. Then they move on to the classic posture tests. Ask the patient to squeeze their hand into a tight fist to check for the benediction posture to rule out a high lesion at the elbow. Ask for the OK sign to check the anterior interosseous nerve branch.
What about sensory testing? How do you map a numb finger accurately?
They map sensation meticulously with light touch, cotton swabs, or gentle pinpricks. The text notes a critical anatomical fact. The fleshy pulp of the index finger is the median nerve's most reliable autonomous zone.
Autonomous zone.
Meaning absolutely no other nerve overlaps its territory there. If the index pulp is numb, the median nerve is definitively in trouble.
Okay, and then we have the special name tests just for carpal tunnel at the wrist, Tinel's sign and Phelan's sign. I've actually had a doctor do these to me.
They are the classics. Tinel's sign involves the doctor literally tapping their finger firmly and repeatedly over the patient's carpal tunnel at the wrist. If the nerve is irritated and swollen, tapping it will send a jolt of unpleasant electric tingling shooting right up into the precision fingers.
Yep.
Phelan's sign is a provocation test. You have the patient hold their wrists completely flexed, usually by pressing the backs of their hands together in front of their chest for a full minute. This physically squashes the tunnel to its absolute minimum volume. If it reproduces the numbness, it's a positive sign.
And the flick sign.
They will also ask about the flick sign. Does the patient have to wake up and violently shake or flick their hand out in the middle of the night to stop the agonizing tingling?
But the expert text gives a postgraduate upgrade to these classic tests. It challenges the textbook a bit.
It does. It states that the most sensitive, reliable bedside test for carpal tunnel is actually Durkin's carpal compression test.
Does that work?
Instead of just tapping with one finger or having the patient awkwardly flex their wrists, the doctor simply presses both of their own thumbs directly and forcefully over the patient's carpal tunnel and holds that immense pressure there for 30 seconds.
Oh, no.
The direct, localized mechanical pressure reproduces the symptoms much faster and more reliably, statistically outperforming both Tinel's and Phelan's.
It's just brute force, direct targeted pressure.
Yeah.
Makes total mechanical sense. And for the high lesions, there's a visual test called Ochsner's clasping test.
Yes, Ochsner's clasping test is elegant in its simplicity. You ask the patient to firmly clasp their hands together, intertwining all their fingers like they are begging. If they have a high median nerve lesion, the index finger on the injured side simply fails to bend along with the others.
It just sticks out.
It physically cannot curl, so it stands completely straight up out of the tightly clasped hands. The pointing index reveals itself instantly.
It sounds like parlor tricks, but it's pure, inescapable anatomical logic. But I have to ask about technological backups. It's the 21st century. Do doctors just rely on tapping wrists and asking people to make OK signs? Or do we have advanced machines to prove this?
No, we absolutely have machines, and they are critical for surgical planning. While the initial diagnosis is primarily clinical detective work, investigations are the final objective proof. The absolute gold standard is nerve conduction studies, or NCS.
How does that actually work? What are they measuring?
It's pure biophysics. They place small recording electrodes on the skin over the muscles of the hand. Then they use a stimulating probe to send a tiny, harmless electrical shock down the nerve at the wrist and again at the elbow.
Measuring the speed.
A computer then measures exactly how fast the signal travels down the arm, the conduction velocity, and how strong the electrical amplitude is when it finally reaches the muscle.
So they're clocking the speed of the express train.
Precisely. And here is the genius of it. We have myelin sheaths wrapping our nerves. Myelin acts like biological rubber insulation, allowing the electrical signal to jump rapidly down the nerve. When a nerve is chronically crushed in the carpal tunnel, that myelin insulation gets physically squeezed, thinned out, and damaged.
So the signal leaks.
Without insulation, the electrical signal can't jump quickly. It has to crawl painfully slowly across the damaged segment. So, in carpal tunnel syndrome, the NCS will mathematically show a prolonged latency across the wrist. The electrical signal is literally moving slower as it struggles to get through the crushed tunnel.
It puts a definitive objective number on the traffic jam. The surgeon can point to the screen and say, your nerve is conducting at half the normal speed right here.
Exactly. It confirms the diagnosis, rules out other neuropathies, and quantifies the exact severity before a surgeon ever agrees to pick up a scalpel. But the text adds a vital, potentially disastrous warning for acute trauma. In a fresh injury, like a nerve severed by glass today, you have to remember the 2 to 3 week delay.
What delay? If a wire is cut, shouldn't the machine show zero signal immediately?
You would think so, but biology is tricky. When a nerve is cut, the part of the nerve disconnected from the spinal cord doesn't die instantly.
It doesn't.
No, it takes weeks for the severed axon to undergo a process called Wallerian degeneration, essentially dying back and dissolving enough for the electrical changes to conclusively show up on the machine.
Oh, wow.
If you test the muscle 3 days after a knife wound, the severed nerve stub might still conduct a residual charge, making the test look falsely normal. You have to wait for the wire to fully degrade to prove it's cut.
Wow. Good to know. And alongside the electrical tests, they can use ultrasound or high-resolution MRI to actually visually look for a swollen nerve or maybe a cyst or a tumor compressing it, and simple x-rays to spot the supracondylar or wrist bone fractures.
Yes. In modern practice, bedside tests raise the intense suspicion, but nerve conduction studies and advanced imaging are the key confirmatory lock.
All right, so the diagnosis is complete. We've mapped the damage. We've measured the speed of the failing electrical signals. This brings us to the final, arguably most dramatic part of the text, the road to repair. How do we rebuild the eye of the hand? The text explores a surgical ladder, starting from the simplest bottom rung and ascending to pure biomechanical engineering. Let's start at the bottom.
The bottom rung is conservative treatment. This non-invasive approach is used when the doctor determines the nerve will likely recover on its own. The neuropraxias, the mild intermittent carpal tunnel syndromes. The very first step is remarkably simple: a night split.
Just wearing a rigid Velcro brace to bed. How does that cure a nerve?
It's all about anatomy. As we discussed, when we sleep, we naturally curl into a fetal position and deeply flex our wrists. Flexing the wrist acts like a vice, crushing the carpal tunnel for 8 hours straight while you sleep.
Right.
A rigid splint physically prevents this. It holds the wrist in a neutral, perfectly straight position. This maximizes the volume of the tunnel, taking all the mechanical pressure off the nerve so its micro blood vessels can open up and it can heal. You combine that mechanical splinting with treating the underlying disease, like giving thyroid medication or waiting for a post-pregnancy fluid to resolve, and sometimes you utilize a targeted steroid injection.
A steroid injection into the tunnel.
The doctor injects corticosteroids directly into the carpal tunnel to aggressively shrink the inflamed, puffy tendon linings.
So the injection is literally chemical crowd control, just shrinking the puffy winter coats to get them out of the subway car.
Precisely. And for a neuropraxia, after a closed fracture, you splint the arm to prevent the joints from freezing up into contractures, you do rigorous physiotherapy, and you watch closely for an advancing Tinel's sign.
Advancing Tinel's, meaning the tingling moves.
Yes. Remember that axons grow at roughly 1 millimeter per day. As the nerve slowly wakes up and regrows down the arm, the front edge of the new nerve growth is hypersensitive. So, as the doctor taps down the arm week by week, the spot that triggers the electric tingling will physically move further down the arm, proving visually and tactily that the nerve is successfully growing toward the hand. Many mild crush cases settle perfectly with just this watchful waiting.
But when conservative treatment fails entirely, or if the nerve is literally cut in half by a pane of glass, we have to escalate. We climb the ladder.
We move to surgical decompression. For chronic, severe carpal tunnel, the definitive operation is a carpal tunnel release. It is elegant in its brutal simplicity.
What do they do?
The surgeon makes an incision, finds the thick, tough transverse carpal ligament at the roof of the tunnel, and literally cuts it wide open. They divide it completely, either through an open palm incision or endoscopically through a tiny tube using a camera.
Just slice the roof.
Once that thick, fibrous roof is sliced, the rigid tunnel springs open, the internal pressure drops to zero instantly, and the suffocating nerve can finally breathe. Over time, the body bridges the cut ligament with scar tissue, permanently expanding the size of the tunnel.
That's amazing. But what if the nerve isn't just crushed? What if it's severed? The neuromesis.
Then you need primary nerve repair. A clean, sharp laceration from a knife is repaired directly. A microsurgeon sits in the operating room for hours, peering through a powerful microscope using synthetic thread finer than a human eyelash.
Incredible.
They painstakingly stitch the microscopic outer guiding tubes, the epineurum, back together. They must align the bundles of axons perfectly without any tension, hoping the regenerating fibers find their way across the microscopic gap.
I have a hypothetical.
Yeah.
What if a massive chunk of the nerve is totally destroyed, like in a severe industrial crush injury or a gunshot wound where the surgeon has to cut away 2 inches of dead, mangled nerve tissue? The 2 healthy ends of the nerve can't possibly reach each other to be stitched together anymore. What then?
In that devastating scenario, they bridge the massive gap with a nerve graft. They take a spare, less important sensory nerve from elsewhere in the patient's own body, commonly the sural nerve from the back of the calf.
From the leg.
Yes, the sural nerve is long, easily accessible, and its only job is providing a little patch of sensation to the side of the heel. So they harvest a long strip of it. They use that piece of dead leg nerve as a biological extension cord to bridge the massive gap in the arm.
It's exactly like auto repair. It's like a mechanic cutting a piece of useless speaker wire from the trunk of your car to patch the vital, broken ignition wire under the hood. The body is just a machine of wet wear cables.
It is a perfect, highly accurate analogy. The harvested nerve graft is functionally dead, its internal wires degrade, but it provides those vital, empty, microscopic plastic tubes. It gives the living median nerve in the arm a pre-made tunnel system to grow through to cross the gap. But the postgraduate points here, the true surgical marvels, go even further than splicing biological cables. We have to talk about tendon transfers.
Okay, this blew my mind even more than the Martin Gruber anastomosis glitch. Explain how a tendon transfer works and why you would ever do it.
So imagine a patient has a completely dead median nerve from a high injury at the elbow, and it wasn't repaired quickly. Or maybe the graft failed. The feiner muscles in the hand have wasted away entirely. The thumb is a tragic ape thumb, flopping uselessly in the plane of the palm.
Right.
Even if a brilliant surgeon perfectly repairs the nerve at the elbow today, remember the speed limit, nerves grow at 1 millimeter a day. It might take a year and a half for those slow-growing electrical axons to reach the hand.
Too slow.
And by then, the tiny thumb muscles might be so shriveled, scarred, and dead that they will never respond to an electrical signal again. The evolutionary opposition is permanently, irreversibly dead.
So the patient is just stuck with a useless ape thumb forever. The hand remains functionally blind and mechanically broken.
Not if the surgeon performs an opponent's plasty. Plasty comes from the Greek meaning to mold or reform. The surgeon accepts that the thumb muscles are dead. So they ingeniously recreate the mechanical pull of the dead thumb muscles by borrowing a healthy, strong muscle powered by a completely different, intact nerve and rerouting it.
Rerouting a functioning muscle. How do you even do that without ruining the rest of the hand?
You find a redundant muscle. They unhook a working tendon from its original insertion point on the bone, tunnel it under the skin of the palm, and re-anchor it tightly to the base of the thumb bone at the exact biomechanical angle needed to pull the thumb powerfully across the palm.
Wow.
The text mentions a few classic, brilliant options, taking a slip of the tendon that flexes the ring finger, or using a muscle on the back of the arm that extends the index finger. But the most vivid, famous example is the Kametz transfer.
Yes, let's talk about the Kametz transfer. This involves a muscle that some people don't even have.
Exactly. Surgeons can perform this neatly during a severe late-stage carpal tunnel release where the thumb muscles are already dead. There is a long, thin muscle in the forearm called the palmaris longus. It is an evolutionary leftover. It is so functionally useless to modern humans that roughly 15% of the population is born without it and never even notices.
Wait, 15%. If you're listening right now, touch your pinky to your thumb and bend your wrist slightly inward toward you. If a rigid tendon pops up right in the middle of your wrist under the skin, you have a palmaris longus. If it's perfectly flat, you don't.
That's the exact clinical test for it. It's the ultimate biological spare part. In a Kametz transfer, the surgeon disconnects the end of the palmaris longus tendon from the palm fascia, routes it carefully under the skin over to the thumb, and sews it tightly onto the thumb bone. When the patient wakes up and naturally flexes that forearm muscle, it now forcefully yanks the thumb into perfect opposition.
But wait, how does the brain handle that? The brain thinks it's just flexing the wrist, but suddenly the thumb swings across. Does it take years to learn how to use it?
The neuroplasticity of the human brain is astounding. Through focused physical therapy, the brain quickly rewires its own motor cortex to understand that firing that specific forearm muscle now equals swinging the thumb. It seamlessly integrates the new biomechanics. It literally gives the thumb its evolutionary swing back.
It's biomechanical engineering of the absolute highest order. The body is completely modular if you know what you're doing.
It truly is. And the final rung on the surgical ladder is even more cutting edge: distal nerve transfers.
Because growing a nerve all the way from the elbow down to the hand takes way too long, and the muscles die waiting.
Exactly. Time is muscle. Nerves grow at that agonizing 1 millimeter per day. From the elbow to the fingertips is a massive journey. The intricate hand muscles will die of electrical starvation before the signal ever arrives.
So what's the shortcut?
Instead of waiting for the express train to rebuild its tracks all the way from the elbow, surgeons look for a spare, perfectly working nerve branch right next to the dead muscle down in the forearm. For example, they might take an expendable, redundant nerve branch that currently powers a wrist extensor, which is powered by the radial nerve, cut it, and plug that live wire directly into the side of the dying anterior interosseous median nerve lower down in the forearm.
They are literally hot wiring the human nervous system.
Yes. They hijack a local, healthy power source and plug it directly into the dead electrical grid just inches away from the target muscle. It brings the lost muscles back online exponentially faster than waiting for a graft to grow down the whole arm. Decompression, microscopic repair, biological grafting, tendon transfer, and nerve hot wiring. That is the complete miraculous surgical ladder for saving the eye of the hand.
Okay, we have covered an immense, staggering amount of ground today. We've gone from the tangled roots in the armpit, down the express train, through the crowded subway of the carpal tunnel, and into the exacto knives and microscopic threads of modern surgeons. We need to tie this entire anatomical epic together into a grand synthesis.
The source text provides the ultimate elegant surgical rule of thumb to remember the 3 great nerves of the arm and their signature disasters. If a listener remembers absolutely nothing else from this deep dive, they should remember this clinical picture.
The rule of 3.
Yes. First, the median nerve equals the lost fist, the tragic hand of benediction pointing upward when attempting to close the hand in power. Second, the ulnar nerve equals the claw at rest, the ring and little fingers curled up permanently in a passive, resting spasm.
And the third.
And third, the radial nerve, which we briefly discussed as the nerve that opens the hand against gravity when it fails, it equals the wrist drop. The hand hangs completely limp and cannot be lifted upward. 3 major nerves, 3 devastating deformities. Each one is simply a physical picture of muscles that have fallen entirely silent.
It's the surgeon's way of looking at the body.
Hmm.
As the text insists, anatomy isn't just a list of Latin words to be memorized. It is an interlocking mechanical logic to be deeply understood. Well, I want to thank you for expertly guiding us through this incredibly dense, fascinating map of human wiring.
It is a profoundly humbling subject. The sheer staggering complexity of our own hands is something we completely take for granted every single time we type an email or tie our shoes or pick up a coffee cup.
We absolutely do. But before we wrap up this deep dive, I want to leave you, the listener, with a final lingering mystery to ponder. It's something we touched on briefly when discussing the horrors of nerve trauma, but its philosophical implications are vast. We talked about causalgia, that severe, agonizing, unrelenting, burning pain that happens when the median nerve is severely crushed or partially severed. A terrible condition. I want you to think about this logically for a second. If a nerve is totally crushed or sliced, meaning the biological cable is cut, the fiber optics are shattered, and it physically shouldn't be able to send any electrical signals up to the brain, why does the brain often interpret that pure physical silence as an agonizing, fiery pain?
That is the big question.
What does it say about the underlying architecture of the human mind that when the eye of the hand goes totally irreversibly blind, the brain absolutely refuses to accept the darkness? Instead of experiencing nothingness, the brain fills that terrifying void with the hallucinated sensation of fire. I invite you to explore the fascinating, sometimes terrifying world of phantom pain, neuroplasticity, and nervous system hallucinations on your own. It proves that what we feel every day isn't just a direct recording of what's physically out there in the world. It's a complex, constructed reality, and sometimes it's about what the brain desperately decides to invent when the wires finally get cut.